Welcome. I'm Andrea Baer with USAID, and the Healthy Markets Community of Practice, as most of you know, is co-sponsored by USAID and UNFPA, and we're very appreciative of having FHM Engage as the secretariat, and we generally focus on one country each month or session. We are going to have some sessions coming up later that will be thematic in nature, so stay tuned for that. And just a reminder to stay on mute and put questions in the chat. Usually our speakers are quite good at being able to see those and reply after their portion. And then we will have a good run through and we'll have time for Q&A. So with that, Ben, over to you.
Thank you very much, and thanks, colleagues. Thanks so much for making the effort to join the call. So I think this is a really exciting opportunity for the Healthy Markets Community Practice to focus on Nepal, and we are here to engage with key stakeholders in Nepal to learn about and understand what's happening in your country. The very rich presentations focus on one of three themes principally, so family planning users, the private sector, looking about engagement and development, and also sustainability. And as we listen to and reflect on the presentations, certainly I'll be trying to keep in mind why we're having this conversation. And I think it's because we feel that healthy markets, particularly in the context of family planning and contraceptives, can play a crucial role in meeting overall family planning needs. I'll also be trying to be mindful of the overall context of family planning in Nepal. We note that modern contraceptive prevalence rates have stalled. There is an increase in the use of traditional methods. There's also increased recourse to abortion. We also note that the total fertility rate is on a downward trajectory. Donor funding is also down, and governments, including in Nepal, are increasingly being encouraged to allocate more domestic resources to meet family planning financing needs. And I think this actually is a significant opportunity for the commercial sector in the context of family planning in Nepal. And we really need to catalyze stimulate the work of the private sector to serve those who can pay for their services and products. So we're also looking at improving the market environment for the private sector and how that can help overall national efforts to achieve Family Planning 2030 objectives. We've got 6 presentations. I'm not going to go into detail. I think everybody's got this information. So without further ado, I think I'm handing back to Judy to lead us off. Thank you very much.
Thank you so much, Ben. Thank you for that message from UNFPA, the co-sponsor of this Healthy Markets Community of Practice. And with that, I'd like to welcome Farhan Yusuf back to the Community of Practice's Secretariat. Farhan is a seasoned pharmacist with over a decade of experience in health system strengthening in Tanzania. Having led the FHM Engage program, he is now a fellow at Results for Development Institute, and he will be co-facilitating this Healthy Markets Community of Practice webinar with me and those going forward, a role he is delighted to return to. Over to you, Farhan.
Looks like I have forgotten how to unmute myself. Thank you so much, Judy and Andrea, for that welcome back. So happy to be back and be able to engage with this amazing community and have the conversations that we love to have, private sector, FP, SRH. So as has been mentioned previously, we have a great lineup of speakers today, and I think we can jump right into that since we always have limited time, and I know we want to leave a lot of time for discussions later. So to start us off today, I would like to invite Shankar Narayanan from the FHM Engage team to provide a sort of I would say level setting presentation on the market in Nepal. Welcome, Shankar.
Farhan, and good morning, good afternoon, good evening to all of you, the community of practice. I'll be followed by the key presentations, but I just wanted to set the context from FHM Engage. As many of you are aware, FHM Engage works to identify and address root causes of local market underperformance related to the core functions, supply and demand, and the associated enabling environment. Today's presentation, next slide, please. So today's presentation is, we're just going to select some selected content, discuss the market description. The purpose, of course, is to start a conversation, reveal opportunity that informs market development. Why and what are our objectives in Nepal for FHM Engage? Like Ben mentioned, I think the objective was to improve long-term sustainability of the family planning health market through a balance between equitable access to commodities and incentivizing new market entry for different market segments in FP. There are three key questions that we started our work with last October. The first was, how can we strengthen evidence and propose approaches to embed a total market approach in Nepal government stewardship for achieving FP 2030 strategies? Followed by what barriers in government of Nepal rules and regulations that need reforms to incentivize commercial actors to start actively investing and thrive in a small but growing market. And third, of course, is what's the optimal market segmentation and innovative pricing or 4P strategies that will define entry points for social and commercial enterprises to fulfill sustainable business models. One of the things that I wanted to emphasize was we have already done an intense dissemination round of events in Nepal. And at the end of this presentation, you will receive the health market links. So you have a complete construct of two of the three products that have come out of this work. So first, the complete family planning market description in Nepal. The second is the market sizing and the segmentation that you have done in Nepal. It'll be followed up by a report on government of Nepal's rules and regulations that needs reformation to incentivize commercial and social marketing actors to start actively growing the market. So that's the construct and the objective that we entered Nepal with. And this is a very select content that we're presenting. Next slide, please. So as usual, we start with the FP user. Navraj, who follows me from UNFPA, will be giving you a deep dive into what's happening in Nepal. But a couple of big call outs. Next slide. I think despite NCR remaining flat, one of the things that stands out is over the last 4 rounds, we see an increase in traditional method. Nepal has reached its replacement rates, and one of the things that stands out is that women. There's a slight decline in the proportion of women not wanting to get pregnant, but did not use contraceptives. So while everything is appears to be okay, MCPR seems to be stagnating for the last 3 rounds. Next slide. Depending on the numbers or the statistics, we now know that anywhere between 350,000 to 500,000 Nepali men leave Nepal, migrate outside Nepal. One of the things that we thought that this could be happening in Nepal, based on the DHS 22 survey, was the absence of ongoing need for contraceptives, with infrequent sex being a cause and husband away. We also did an analysis of induced abortion. So, and Navraj will be presenting a more deep dive on that too. These are some of the call outs that we had. One of the things that I wanted to highlight was that this out-migration and infrequent sex will potentially change the way the market grows over the next decade in Nepal. And I also wanted to highlight a quick snapshot on who is the market currently underserving that we identified in our analysis. The market is currently underserving the young and interestingly, the higher and the middle income populations. One of the things that's happening in Nepal is, as we said, increase in use of traditional methods it's even more so among the higher and middle income quintiles. And that's where we feel at least the commercial and the social marketing opportunities lie for short acting methods. Next slide, please. Look at the next lens, private sector growth and sustainability. Next slide. So we did an assessment of all the methods that are available in private sector in Nepal. This includes short-acting methods, long-acting reversible methods across both chemists and as well as clinic and hospitals. And so a quick snapshot reveals that there appears to be great breadth of brands available in Nepal. One of the biggest call out, of course, is what's happened over the last 3 to 4 years since the last private sector retail audit was done, was the growth in emergency contraceptives. We now have 14 plus brands in Nepal of emergency contraceptives. We now have a very strong presence of both imported as well as locally made oral contraceptive pills in Nepal. Condoms, of course, a lot of brands from India and those that are imported from other parts of Asia. Next slide. So I just wanted to give you a quick snapshot. So when we did the market description, it's important to emphasize that CRS, which is a dominant social marketing player, has a huge market share. And that will be demonstrated in some of the statistics that Jublal will present later in the queue. So at the topmost, we have CRS, which is a social marketer, and the way we have predicted and estimated what would be the other private sector market share for condoms, oral contraceptive pills, injectables, and emergency contraceptives. Then on the left side, you've got the 4 key market actors. So we start with manufacturers, then we come to distributors and associated logistics and supply chain issues. Then we've got the point of sale, necessarily chemists. So we are looking at short-acting methods. And of course, what are some of the pricing? Just some key takeaways are, Nepal now has a slow and nascent, but an emerging opportunity for local manufacturing, specifically for oral contraceptive pills and emergency contraceptive. Like I said, CRS continues to play a dominant role. And one of the things that we see between two DHS is that CRS has managed to have a great penetration across urban and rural and across wealth quintiles. In an era where we certainly can predict that subsidies will no longer be available, this dominance is both a concern, and we'll come to that later. Post-COVID, I think one of the things that has come into the observation is that the reach of Indian companies has significantly suffered. This appears to have been an incentive and a motivation for the local Nepali company to have done well. There's tremendous point of sale opportunities. Nepal has close to around 30,000 chemist outlets. And CRS has got presence for short-acting methods across 23 to 24,000 outlets. And it's important to understand that Nepal has one of the strongest networks of pharmacists created through the Sangiri network investments by USAID over the last 20 years. And so you have a strong community of pharmacists who deliver both primary healthcare. Pricing is a key issue. So there are price controls in Nepal. And one prediction was there's a lot of headspace for private sector to expand choice in short-acting methods and long-acting reversible methods. Next slide.
Shankar, if we can quickly summarize. Thank you.
Yeah. So this is my last slide. We did the small area analysis, and we have estimated the private sector value for short-acting methods. Using the current private sector method mix, the estimated value of the 4 types of contraceptive modern methods can be anywhere between 7.4 to 7.9 million. So this goes back to how I was articulating that there is still a lot of headspace for commercial marketers to come and participate. And as a final slide, I wanted to remind that for these 2 bits of work, the market description, which has got the complete analysis of the market for family planning, and the market sizing, you can access it in health market links. Key takeaways: Stalled MCPR suggests a mismatch between product and promotion fit. Public sector and social marketing can improve resource allocation to better serve vulnerable populations and lower wealth quintiles. There's a significant FT opportunity for oral contraceptive pills and condoms, specifically for private sector, to serve those who can pay. We talked about the CRS dominance, and CRS necessarily is in the process of transforming themselves into a social enterprise, which can become commercially sustainable. And of course, finally, there are several rules and regulations that can accelerate private sector participation and help achieve the government's FP 2030 objectives. Thank you.
Thank you so much, Shankar. And the one thing that stayed with me from your presentation is this element of increase in traditional methods, because I remember even when we were presenting for Tanzania, that was a trend that we had seen, and it's quite interesting to me. It's being seen in other countries, and more so, at least I remember for Tanzania, we were seeing an increase in traditional methods even in the urban areas, right? Which is, I think, quite interesting, and hopefully we can talk a little bit about it, or maybe we'll find out more about that from Navaraj's presentation, which is next. Welcome, Navaraj Bhattaraj from UNFPA Nepal.
Thank you. Thank you for your introduction, and then thank you, Shankar Narayan, for presenting so well about the family planning program, and it's always great to hear you. So I'm going to build on some of the informations that already have been presented here. So you can quickly find the title of my presentation. So I will be talking more from recovery to resilience, and then how we supported and promoted for the sustainable financing in Nepal, and what we have been doing as a country to bridge between the access and the availability of quality family planning services in Nepal. Next slide. Okay, so this is I think some of the information has already been presented here, but I want to provide the things in the nutshell. The slide shows that the total fertility is decreasing, and it's at the replacement level, whereas the adolescent fertility rate is still high at 71 per 1,000. And then the unmet need is still high, 21, where what the Shankar has already described what can be the possible reasons. And I have already also mentioned the half of the pregnancy, as for our latest estimate, it shows that half of the pregnancy is unintended, and among them 2/3 in abortion, and still half of the abortion is being outside the legal setting in an unsafe way. Although the family planning is it's long withstanding program, the service is being provided through the lowest unit of health structures, and to increase the access, the service is also being provided through the camp, and then through our FCSB, which are the largest network of lay volunteers at the community. And then the public sectors, it is around the share of the non-public sectors, private and the NGO sector, is around 30%. Next slide. So this is the trend of the family planning indicators. I want to show that has already been presented since 2006. Our MCPR, modern contraceptive prevalence rate, is stagnant at 44.2. However, we have shown a little decrease in the unmet need. Although we have already, witnessed three major external factors. One was earthquake 2015, which causes a significant, challenges, and then in halfway there was a federalism, which completely changed how the family planning service was being provided in terms of organizations, and then the COVID. Among these new challenges and new structures also, we were able to decrease the unmet need. But as Shankar Narayan had mentioned, Nepal is a unique country where about 1/3 of the married couples are not living together. So they are they are separated, and then the most of the youth are going abroad for the work. If we only look at the cohabitating among the married couple who are together with their partners, we can see the very sharp decline in the unmet need. But when only looking at the gross, it is not telling about a lot of other patterns going around. So this is also what I want to focus is probably for the countries like Nepal and some other countries which has high rate of migration. It is the time to think about the algorithm, how we calculate the unmet need, because it is not sometimes presenting the true pictures. Next slide, please. So I'm going, already it has been presented, commodity security and then expanding choices. So we are adding the new contraceptives also. Now we have already have presented what are the contraceptive method options available. To talk about some of them, we have been supporting government of Nepal in terms of piloting the sign-up race and scale-up. So around now it is being scaled up through provider-based approach, but we have also been discussing about the self-injection of sign-up race, and then the upcoming piloting of implant of 3 years effectiveness. Probably that would happen after a few months as the government is procuring the 3 years implant. So we are supporting the government in expansion of the method choices. About the ECP, what you have mentioned, it is now the ECP is being mainly provided through the private sector, but from last few years, 2 years back, it is added in the contraceptive basket in the government, in the list of contraceptive which is provided free of cost. Although it was being provided from the private and then the social marketing and the NGO sector from a long time, but from the public sector it was not there. Since 2015, Nepal already received around 12 million USD, commodities of worth around 12 million USD, which is mostly going to the government, and UNFPA contributes around 60% of the total commodities that is being utilized from the public sectors. And we can see the stock out of the commodities is decreasing. There has been some typos, but the latest government report shows that the average stock out of 3 commodities is at 8%, which is now in decreasing trend. So we are progressing well in terms of securing the commodities as well as increasing the contraceptive choices. Next slide, please. So what about the availability? So there is I want to show 2 graphs here, 2015 and then 2021. It is based on the Nepal Health Facility Survey, which shows that the provider, the facilities that is providing the LARC methods has been increasing. Although there are a lot of space, lot work need to be done, still implant is being provided in less than half of the facilities. But if we compare from 2015, it has been almost doubled. But whereas in terms of uptake, it has been, there has been a very sharp increase from 1.3 to 6.1%. And then one thing to be noted here is that LARC is mostly being provided through the public sectors, and then the NGO sectors only contributes around 9%. So since the LARC implant and especially implant is being is now the most preferred method, I think there is a significant role from the private sector and then NGO sector to increase the access of the implant service as well. So we are supporting the government in different initiatives like a capacity building of health workers to increase the access of this service, and then the essential equipments, as well as deploying the different kind of unique models to bridge between the access and then availability. This roving ANMs and then the visiting service provider, which has been like the very successful models in Nepal to reach a large number of populations. Next slide, please.
Navraj, if we
So-
can quickly summarize, please. Thank you.
Okay, sure. I think this is going to be my last slide. I think this is the, when it's about the FE financing, the most of the short contraceptives, it is provided free of cost at the public health facilities, and other services are also provided free of cost from the public health facilities, although these are not a part of the universal health coverage. FP 2020 commitment, earlier commitment was 7% increasement per year. We have also already, included financial commitment in this FP 2030 commitment, where we have committed, jointly committed, government and then the partners have committed to increase the budget. And then as per the costed plan, we have prepared the costed implementation plan, which is now in the approval stage. And then we have also come into the co-financing agreement with the government to increase the 1% contribution. So what Shankar Narayan had mentioned, the budget is in decreasing trend, and when it comes about the government expenditure, it is mostly coming from the federal sources. Around the 94%, 95% is coming from the federal source. Next slide, please. Okay, so in terms of policy environment, I should say it is FE service is constitutionally guaranteed right to specific act mention about family planning service. We have prepared the costed implementation plan, which is second in row. Already we have finished the complete implementations of the first round of FPCIP, and the reality of these days is like we need to expand the concept of family planning and address the infertility as well, because family planning is assisting the couple on the both way, who want to space or limit the pregnancy, helping them as well as those who want to make the children. So we need to expand the concept of family planning, and this discussion has been already started in Nepal, and somehow we are addressing in the current policies also. Next slide. Okay, so there are certain opportunities going forward. One is, like, as I said, FP costed implementation plan, where we have included the high impact practices with detailed analysis of specific needs, and then the projected resource. We have projected the resources, and then we also know where the gap is. And as we said, like, as I have mentioned, like, there is a decreasing funding trend from the government. We need the funding diversification also. Another is definitely the area for PPP through a win-win framework. We need to come with a very win-win framework, which is currently lacking in family planning program. And another is the policy on the UNFPA sale of the UNFPA procured commodities, where we'll develop an implementation plan, based on the policy, and we will involve the key partners with in-depth knowledge and experience around the market development. And we need to reposition family planning as a cost-effective investment, because as the fertility goes down, we know the family planning program is not receiving the same priority as it used to be before. So still the people carry that the family planning is population control measures, and they are looking from that lens. That's the end of my presentations. Thank you.
Thank you so much, Navraj. And your presentation definitely added to the context that Shankar provided. Both presentations really sort of emphasized on the fact that donor funding is declining, so we need to think a little bit more about that. And I think our next presentation by Vishal from Senador Labs will show us how to launch quality assured new products with commercial viability, which I think is interesting in line to what we have heard so far. Welcome, Vishal Takarkhere.
Yeah, hi. Hello, everyone. Nice to meet you to everyone virtually. I'm Vishal Takarkhere from Senador Labs. So Senador basically is earlier we were Mylan from Mylan. So Mylan has Mylan's women healthcare business has been acquired by Insud Pharma. So Senador is a demerged entity of Mylan. So next slide, please. Yeah, next. So we are continuing our efforts to ensure that women should consistently have access to high quality contraceptives. We are a major supplier of OCPs in emerging market, and more than 16 million women are using our products. We are committed to maintain standards and provide access to quality products globally. Next slide. So in our range, we have a range of portfolio which includes the contraceptive range, which has combined oral contraceptives, progesterone-only pills, emergency pills, injectables, and abortion kit. In oral contraceptive pills, we have from first generation to latest generation, that is new generation progesterone combinations in our portfolio, like drospirenol plus ethinyl estradiol combination. So in Nepal, next slide. So in Nepal, we have 4 products. Next slide, please. So in Nepal, we are present with 4 products, that is levonorgestrel with ethinyl estradiol, with ferrous fumarate, as well as with placebo. And we also have injectables and emergency contraceptive pill also we are marketing in Nepal. So, next slide. So we have conducted a small survey at personal level in Nepal where we were planning to launch new generation progesterone through private market. So that was our objective. So to focus on or to launch the new product. So we have conducted a small survey last year. So these were some few findings where we were trying to know about the awareness about the new generation progesterone combinations and the different methods which have been used. So the awareness, if we see in the new generation COCPs, it was limited to the HCPs, but the end users or the pharmacist level, it was minimal been known, especially in the rural areas. But of course, in the cities area or the urban areas, everyone was aware about the new generation contraceptive pills and the benefits of that new generation progesterone pills. Wherein the prescription pattern, if we see, it was more interesting. It was found that this contraceptive pills basically was prescribed on more for the cycle regulation. If any user is coming for menorrhagia condition, so they will prescribe one strip of contraceptive pill and one painkiller and 4 or 5 tablets of tranexamic acid. So this was this prescription the user will take for 1 month or 2 months. Once her bleeding gets controlled, she will discontinue this oral contraceptive pill. So basically the actual indication of preventing the pregnancy is left behind and the cycle regulation takes place. So here the total indication is more decline towards the non-contraceptive benefits. So rather than giving the contraceptive action to the user. Moreover, the purchasing, when we and try to know if we want to launch a new generation which is a bit costly product than the existing ones, so even we found that the users are ready to spend out of the pocket or spend extra money also if they get additional benefits than rather than if using the regular contraceptives. Like if my bleeding is getting controlled, so of course they are ready to pay. They are approximately around Nepalian rupees 300. They are ready to spend, or they are ready to purchase these kind of pills if they are getting additional benefits. So on an approximate, I can say that 300 rupees is okay for them. Then availability is the major concern which we have observed. Most of the time, this as we came to know from the Shankar slide also, that the products are mostly imported from the India and the Bangladesh. Now when the products is available, it's okay. But once after few months, within 3-4 months or so, the products gets liquidated in the market, and then to to make it available, the supply chain is getting a problem over here because it doesn't get fulfilled. It takes months, around 2 to 3 months. There is a shortage of the product in the market. So even if the user is taking a regular contraceptive for 2 months or 3 months, and after that, if the product is not available, especially these new generation products, so there is a shortfall in the market. So it is due to this non-availability, they discontinue this, and even the doctors are also not reliable or finding it difficult to prescribe this new generation progesterone combination.
सब ठीक है, बताओ क्या खबर है?
So this is what we found in the availability. So continuous availability is a major concern. And so the next slide, please. So looking at this scenario, when we are also interested in to launch in the private market in Nepal, and hello, yeah, we are ready
Yes,
to.
Vishal.
Yes. So we are very much interested to launch our products in Nepal, especially in the private market. But of course, we are also looking forward for certain support from FHM Engage. There are few things like from the point of view of regulatory, that is of registration support. We want to expect. We are expecting that like additional brand. Registration for NGOs. Like we have already having this levonorgestrel with ferrous fumarate product is already registered, but if we want to go in private market, then we cannot register, we cannot have that. So in that case, of course, we would like to support with that. And even the timelines, if we see it takes around a year or so to get the product registered. So that is the one part. Then of course comes as an awareness and the promotion activities. Awareness not only about on the methods of the contraceptive, but also awareness we are expecting about the generation of the progesterone and the usage and the benefits and all those things. So this should not be limited to healthcare professionals, but of course this should be communicated and informed to the end users as well. And the third thing we are expecting for the training part, so the even whatever the capabilities are there. So training for the HCPs and for the resource allocations. So for combined contraceptive pills, and third one is the data sharing. We would like to have certain data. Like recently we have gone through the 2-3 presentations. So all these some presentations from the perspective of the private market, we would really like to have that. So some data so that we can drive develop our strategy and routinely if we get it continuously. So in future also we can refine our strategies and improve our outreach to efforts in the market. Thank you.
Thank you so much, Vishal, for being exactly on time as a speaker. I truly appreciate that, and I think you've brought in a lot of points that we've heard in previous conversations as well, and definitely things that we will hopefully discuss more in our discussion time. Basically, what you said is launching these new quality products is a team effort, and everyone has a role to play, and especially I know this point around data sharing between the public and the private sector is a recurring theme that keeps coming up. And I believe our next presentation by Susan from CARE Nepal will probably add to that, because she is going to talk about digital gamification, which I think is going to be quite interesting and will emphasize on these data related points. Welcome, Susan.
Thank you. Thank you, everybody. So I'm going to talk a bit, well, the game, we'll talk about the game sort of at the end, but so we're the USAID Adolescent Reproductive Health Project, which has many, you can go to the next slide, which I can explain then. So just a snapshot of who we are and what we're doing. I'll focus more on the private sector today, but overall, this is who we all are working together. So CARE is the prime, and our focus is really about all of the gender transformation, all of the norms, working around all of that is really the basis. And I have to say, it really permeates throughout all of the work that we're doing. So we work very closely with ION, which is the youth network in Nepal that feeds into all of our work. So adolescents are part of that as well, but we're using them as near peers in activities. We use them for work to do activism in the communities, for the digital game. And we have Howard Delafield International working on that and all the social media. Whoops. Hello. Okay, I'm back. Sorry about that. And then we have Nepal CRS. We have Jibala on the phone, on the call also, who could correct me if I'm wrong about anything. But really working on the private sector, and then also Japaigo working on the public sector through a mentoring program. The groups on the bottom are all of our implementing partners. Everything is implemented at the local level in 11 districts across 60 municipalities in 3 provinces. And those implementers really conduct all of the activities. So all of the representatives of the different organizations are also based in that area. We're 2 years into the project. You can next. So, I mean, just some things about the private sector and the, so we had some baseline survey findings, of course, and we found this also in our formative research and some similar things. So everyone says, whether it's, you know, government officials, influencers, whoever it is, are saying, and youth themselves, that they love the private sector. They go to the private sector. It's better. They maintain our privacy better. They provide better resources. They're just better equipped, have better services. However, when we actually looked at where are the young people going, they're actually going to the public sector for family planning. So as you can see, the N is very small out of a sample size of almost 6,000 young people. Only 37 of them are actually current family planning users. And only 16% of them are going to private facilities, and most of them are going to government health facilities. So, you know, so we've got kind of, yeah, everybody really likes the idea of the private sector. We really want to go there, but we're not actually going there. Next. So in terms of our major activities in the private sector, so we started out looking at all of the different private sector facilities that are in our areas, pretty much all of them, and then wheedling them down to the ones that were registered, and then the ones that were really able to meet some of our criteria, like they were willing to actually work with us and be partners with the government as well. And so we have identified 275 health facilities that we've now signed MOUs with that work with us closely on the program. We've worked on capacity building. All of them have had adolescent reproductive health training. They've had Sanguini training, you know, and also other methods training, and recording and reporting training. And the whole idea about the recording and reporting is that the higher level facilities, not so much the pharmacies, but the others, will eventually be hopefully going into the public system, HMIS system, with the private facilities and lower facilities reporting to the municipalities, which is the local government. So the idea also is that all of the facilities are also trying to be more adolescent friendly. In the public sector, we have a very strong mentoring program and working on a QA/QI program to be able to ensure that all of the criteria for the certification of adolescent friendly services according to the government are met. With the private sector, it's a little bit different because all of the, I think there are 48 criteria are not able to be met. So we're working with the government to try to figure out, well, what is possible for the private sector, and then working on quality improvement standards with them, with assessment plans. And so our private sector officers who go to all of these facilities to work out how are we doing, making a plan, how to make improvements. And then we're offering some support in terms of IEC materials, which seem to be really not happening at all. And so we've provided IEC materials, some logistics support, so they can actually provide some services. A lot of them had no counseling private space for anyone. And so we've already had great results with that, where about a quarter of them already have already modified their facilities. And then there's also digital interventions that are being used. There's a Sanguini app, which is, you know, for registering the different contraceptives. And then there's the QA/QI stuff, which is all digital. And then the recording and reporting also. So the idea really is that the service providers will provide better reproductive health services for adolescents, and that will also at the same time, though, strengthen the public and private modalities of working, which is a priority for the government as well. And then what I'm not talking a lot about here because we don't have time, is the total market approach. We have a plan which really takes into consideration this whole survey that was done for the private sector, which looked at, where are we, what kind of services do we have? Also the same thing done in public sector, but for about 650 facilities. And then looking at that together to see how are we providing quality services. You can go to the next one. Next. Yeah. So the demand side is very important for us. Obviously, it's great to have the supply, but on the demand side, so we're looking at all the social behavior change and social norms. We have quite a lot of interventions. Right now, we're reaching about 50,000 young people and their influencers in the field through so far direct person-to-person kind of contact. We have groups, and you can see, I don't know if you can see, but all the different kinds of groups. So we have in-school girls, out-of-school girls, in-school boys, out-of-school boys. We have the parents of the adolescents. We're targeting also to make sure that our programs are inclusive in terms of disability, in terms of LGBTQI. We've also worked with the influencers being religious leaders, and we're working with the FCHVs, the female community health volunteers at the community level, trying to really get them to also work with the influencers, which are the women in the community, to really be able to address the needs of pregnant and young mothers. Working a lot with the youth engagement, as I was saying, with ION and their groups. They have groups at the municipal level, and then work also at the ward level to have youth become really more adept at being able to advocate for the needs of young people. We've already had really some great results at the municipal level with the recent budgeting and planning, where already there's some adolescent kind of focus health activities that are getting into the budget. And then the digital interventions, which is, that's next. I'll just go into that. You can show the next slide because it goes into little.
Yeah.
So the digital interventions. Yeah. Am I done?
Susan, if we can quickly summarize. Yeah.
Okay, so there's the digital stuff on online already. Is this virtual influencer? Her name is Ekta. You can look for her. That girl Ekta is what it is on Facebook and Instagram. There's a web portal any day now, hopefully coming live, which will provide all kinds of services and also be able to offer connections to private facilities as well as public facilities, what's out there, answer questions. And then we have this game, which should be able to start, hopefully Girls Hostel, which will have all these virtual influencers in there. And the game is really something that, it's made for 15 to 19-year-old girls. Let me just go to the next slide, which is my takeaway messages or my questions. So just to think about, adolescents prefer, this is what I was saying in the beginning, they prefer the private sector, but they go to the public sector. Why? So is it location? Is it affordability? What's the problem? We're kind of struggling with that. They like the facilities, the private facilities, because they're quick, they don't ask any questions, they're confidential. But at the same time, we're really focusing on, you have to do some counseling. This, we're training people to say, oh, you need to do counseling. So, what young people like, what adolescents like, is I don't have to answer any questions. I don't have to talk to anybody, but we want to offer counseling. We're trying to think about how to send people home, how to send adolescents home with something to think about, because they're not going to probably stick around for any counseling in a pharmacy. In other places, maybe. Private facilities may not what we understand is they're not necessarily available during school hours all the time. So that's also a problem. And sometimes school is good because that's when the girls have mobility. They can move around. They're with their friends. But the private facilities often aren't open at that time. The private hospitals and clinics don't want to report in the HMS system. It ends up being a burden to them, possible paying more taxes. It could be more expensive. Private facilities need to do more outreach. We're going to be working with them, how to link up with schools, how to get more involved in the digital work. And this platform for the public-private facilities to work together. And of course, we've got the Sangini network, which should really help with all the, with having less stockouts in some of the places where we do have stockouts. That's it. I'm done. Sorry. Sorry for going too long.
No, thank you so much, Susan. And this is important because even in other previous discussions, we've seen that youth is that sort of enigmatic crowd that we are all trying to get, and there's so much that we can learn from different countries. And that's why, as Andrea mentioned earlier, as we think about doing thematic sessions, I know youth is definitely something that we are already thinking about in terms of comparing or rather sharing between countries. So thank you for that. Now moving to something very different, but just as relevant as important, thinking about how can we, transform our social marketing organizations into social enterprises. Welcome, Jiblal.
Thank you for that. Can you hear me? Okay. Thank you, everyone. And I think my job has become very, very easy because of the previous presentation. So I think I can skip some of the slides. Today, I'll just want to sort of like highlight the work of the Social Marketing Organization Nepal. And next slide, please. Just for the benefit of those of you who don't know where Nepal is, we are located between India and Nepal. And India and China. And we're proud to say that we have 8 of the 10 highest peaks in the world, or 8 of the highest peaks, which are above 8,000 meters. And much of the key indicators have already been highlighted during the sort of like previous presentation around the youth population, the decreasing trend in fertility, the contraceptive use, and the stagnant more than MCPR, and sources of sort of like contraceptives as well. And the other challenges that was presented by Shankar was that the high migration rate. I'll come back to that later. Next slide, please. Coming back to what Shankarji said and Navra said, the dominant source of contraception in Nepal is the public sector. But the second largest source of contraceptives is the private sector. And the if you look at the two graphs, graph on your right says that the public sector has dominated, and the second one is the private medical sector. This is where CRS works. Others are non-government organization and other sources. And the private medical sector contributes about 23.3% to the total sources. So next one, please. Going back to CRS, we are a social marketing organization, and we were established in 1978, transitioned to a profit not distributing company in 1983. After 2021, we have established a wholly owned subsidiary, and I'll come back to that bit later as well. As of now, we have a full range of short-acting contraceptives, including the injectable, 2 variants of OCP, ECP, pregnancy test kits, 3 variants of condoms, water disinfectants, ORS, long IUD, and Jadel, and also these sort of like lubricants, including some lotions as well. And like I said, we have gone into enterprise model where the parent company, CRS, will work in the donor-funded programs, and CRS Healthcare, which is a wholly owned subsidiary, will be a financially self-reliant sales and marketing of the FP and other health products. Next one, please. This is just to tell you our reach and how we are working. We work with the private pharmacies, and our model is totally, the distribution channel is through the private sector. And we have a central warehouse which receives the procured commodities, repackages them in our own brand. Then we have a distributors, then wholesalers, and then we have a retailers. Like we have already said, Nepal has about 30,000 pharmacies, out of which about CRS products are available in more than 20,000 pharmacies. And out of those 20,000 pharmacies are specially trained network of pharmacies, which is a social franchising network, which are trained to administer DMPA. And recently also the ASRS, adolescent sort of like adolescent friendly services. And within those 3,300, we have about 1,000 outlets which are being trained to provide adolescent friendly services under ARS and Momentum projects. I mean, Suzanne has already talked about ARS, and we'll have a presentation from Momentum, I think, later on. Next one, please. Going back to what we have done, I mean, if you look at the 3 years, 2011 to 2016 and 2022 data, social marketing has been able to penetrate the wealth quintile across the wealth quintiles, as well as the both in the pill segment as well as in the condom segment. And we have received a significant growth in the sort of like penetration in the last 2022 DHS. And if you look at the private sector, sort of like penetration or the market share, we have about 29% market share in the DMPA, and we are the only organization which has DMPA through the private sector, other being the public sector, and some of the NGOs have received donated commodity from UNFPA. And if you look at the condom use, 69% of the condom users use CRS products, whereas 75% of the pill users use Nepal CRS products. Next one, please. And going back to what has been the evolving context for the last few decades was that, like we said, there have been definitely the education level has increased with the higher education and income and more exposures through the social media, and there are higher aspirations and willingness among the higher aspiration among the users, and also you've also seen that there is a higher willingness to pay. That's one evolving context. The other one, we have already mentioned it several times, the high migration rate, which will affect the way that the FP services are, or the FP market grows in Nepal. And even with that, there are underserved segments, and there are focused geographic areas and focused groups where we have not been able to. And last, but I think the most important of all is the decreasing donor sort of like funding on the family planning. And because of this, we were sort of like, compelled to go into a sustainability model, and with the support of USAID and SOS Plus. I think Jeff is here. I'm sure he's hearing me. And Jeff was instrumental in sort of like the design and study of this enterprise. And so we have gone into an enterprise model with establishing a social, a wholly owned subsidiary. And this 2-unit transitioning has happened, and we are looking at the parent company is looking at more of market saving activities, whereas the subsidiary is looking at the more sort of like even increasing sales and penetration in the, or offering the greater variety of the products in the market. Next one, please. Again, coming back to the two enterprise model, on your left is we said CRS Health. CRS will implement the donor-funded activities, looking at the policy activities, market shaping, new products introduction, catalytic funding for new market interventions. And whereas CRS Healthcare will accelerate the adoption of new products, bring about cost efficiencies in distribution channel, strategic supply chain partnerships that we are looking at, and organizational capacity. Next one, please. Okay, thank you very much. But before I close, I mean, much of this sort of like strategy that I presented in the last slide comes from the market description and the market sizing study that was done by FHM Engage recently, and which I think Shankar has made it very clear. Thank you very much.
Thank you so much, Jiblal. Also, in terms of keeping with time, and always good to see, sustainability in action, and seeing, our social marketing organizations, our NGOs sort of move more towards these kind of social enterprise models that guarantee sustainability just a bit more. For our last presentation today, we have Shrishti from FHI 360. I hope you've been able to join again, Shrishti. Thank you.
Hi, thank you so much. Let me know if you cannot hear me, and I will switch off my video to contain my bandwidth. Thank you. Namaste, and thank you for this opportunity. And I'm sharing on behalf of our entire team, the USAID supported Momentum Private Healthcare Delivery in Nepal. Many of us from the project are here as presenters, and also I saw several participants. And considering the time limit, we decided to focus on digital interventions and database decision making. Hopefully, we will have another opportunity and for other colleagues to share more on provider behavior change. Next slide, please. Thank you. So I know like a lot about the context has already been mentioned, so don't want to repeat the data, but I think we can all acknowledge that it's very important for young Nepalis to be able to access quality family planning services from the private sector because of the high unmet need among adolescents and young people. And also studies indicate that private sector is a preference and it's an important source of family planning for this young demographic. And as far as the policy landscape is concerned in Nepal, we do have policies and government guidelines that exist to promote public-private partnership and an expanded role for the private sector in the National Family Planning Program. However, we not only need to leverage these existing policies, and we can all agree that we need to create a more enabling environment and reduce ambiguities in policies and put policies into practical implementation for the private sector to continue achieving national family planning goals. Next slide, please. So in this context, designed to improve family planning services from the private sector, particularly for young people, Momentum Nepal works to improve both technical and managerial capacity of the private sector sites. And we work across 67 municipalities in 6 provinces. We started with 916 private sites engaged with us, and at present we are working with 848 service delivery points, which include hospitals, clinics, and pharmacies, but we work with a majority of pharmacies. That's 76% of this 848 number, to be exact. And we have a staged approach wherein the support that we provide is gradually reduced to assess what all the private sector continues on its own. So intensive stages have several trainings and monthly coaching, mentoring, monitoring. During the maintenance stage, this coaching mentoring comes down to quarterly, and majority of our sites right now will be transitioning to maintenance stage next month. And more than 90 sites that have been engaged with us since the pilot stage in 2021 will move to check-in stage. So that's where we are at right now. Next slide, please. So we work primarily on the supply side. Technical capacity of the private providers. They are trained in adult and sexual reproductive health, in family planning counseling, the use of DMPA injectables, among others. And the project has also initiated a quality improvement process at these sites. That's a big chunk of our approach. On the right side of the screen, you will see the business component, which is basically to link improved quality family planning service delivery to customer loyalty and improved business. And this was done through training, skill building, and targeted community engagement events. The project designed and implemented digital interventions for simple data collection and management, which is the focus of this presentation, and we will talk about it in greater detail below. In addition, at the bottom, you can see their efforts for a more enabling environment as platforms for private providers and government stakeholders are created to come together regularly to review service data, quality data, discuss challenges and priorities, all for better collaboration and family planning. Next slide, please. So the digital interventions that we implemented for database decision making were primarily in 2 areas. So one is to collect service data, and 2, to improve quality of services. So in service data of family planning, the service data of family planning clients is reported by the private sites using DHIS2 system. The system generates dashboards, which enables the private sites to use data to drive both their service delivery and in forecasting commodities needed. Additionally, reporting using DHIS2 has been important because in order to at least initiate reporting from private sites, so that data from facilities like Suzanne said earlier, that can eventually be fed into the national system. We've already started piloting this in 2 provinces. And secondly, talking about the digital intervention to improve quality of services, this was done using a locally developed web-based application that we call Gunastar Seva. Family planning mentors, they use digital checklists to assess quality of family planning services at the sites. And to improve services in line with a more person-centered approach, a client feedback mechanism has been initiated. So there are QR code displays that can be scanned by clients to provide voluntary and anonymous client feedback. Responses are displayed in simple visual graphs in dashboards on the Gunastar Seva app. And using gaps from the quality assessment dashboard and the client feedback dashboard, the private sites, they make decisions related to both their services and their business. So automated data dashboards, they help the program team assess, monitor, and evaluate the quality improvement of the private STPs that are engaged with the project. Whereas the provider-facing dashboard, they enable the private sites to routinely self-reflect for quality improvement. Lastly, we also carry out monthly monitoring of the sites for project indicators, especially to see their performance on like how adolescent responsive they are, their indicators on business and quality indicators that we evaluate, for them to transition from intensive to maintenance stage. And this is also done using the Gunastar Seva app. So mainly automated dashboards that synthesizes this data. It helps us segregate high and low performing sites, and it aids adaptive management for the program team. And I think, the data dashboards, they have been essential to database decision making, both by the program team as well as private sector sites. And this is a very important part of our approach. Next slide, please. So just to give you a quick glimpse of the data for our current project year since October 2023 to the last month when we received the data, that's May, that last month, May 2024, the total FP client visits, as you can see, more than 1,116,000 FP client visits from 866 service delivery points. And for the short-acting reversible contraceptives, all STPs provide short-acting methods. And you can see in the pie chart that adolescents comprise 14% of visits for short-acting methods. And 56% of the visits are by young people of the age 20 to 29 years age group. For long-acting reversible contraceptives, 247 service delivery points were providing these. And the visits are written right next to the name of the method. As we can see, it's a small portion of the method mix. But it's interesting to see that, we have, although it's just 10%, we do have adolescent visits for implant and IUCD. Next slide, please.
See if we can summarize, please. Thank you.
Sure. I'm towards the end. So if just a quick glimpse of the how they're performing, as Suzanne also mentioned, like the quality of the service that they're providing is important. And as you can see, like over time, the low performers in red have gone down and the high performers in green, they go up. And the client feedback that is received, the client feedback is open for all services, not just family planning, because we need to acknowledge that family planning is a very small part of their business. So the idea is for the private providers to value client feedback and value the adolescent and young people as a consumer segment. And that's what the intention of the client feedback mechanism is. And as you can see here, 15% is from adolescents. Next slide, please. So just some challenges and opportunities that we've encountered. So of course, when you're using digital applications, they're bound to be the digital divide, or they'll have private providers may have problems, and we did face this. However, visualization on dashboards are simple and they're helpful. That's what we've realized. And it's also about identifying resources locally, like technology savvy family members or staff in their sites that can support the learning efforts. Secondly, like I've mentioned before, adaptive management has been enabled by real-time dashboards, and that's been important. Thirdly, locally developed applications, they make tailor-made solutions possible. And for us, for example, Gunastar Seva has been developed under our local implementing partner, Nepal CRS Company's ownership. And they've been working with the private sector for a long time, and they can continue. Our idea is that they can continue to adapt and use this application in further programs as needed. And we had a similar experience for client feedback as well. We were using a licensed paid software, but we were not able to tailor it as per the requirements of the private providers. So we eventually developed the client feedback mechanism in the Gunastar Seva application as well, and that was very useful to us because we were able to respond to private providers' needs and constantly adapt. And free and open source software options we feel are a great option for private providers. We've seen, in our during our FGDs and our KIIs that private providers are interested to continue several, interventions such as the client feedback mechanism or the quality assessment tools using free softwares. And currently, we are piloting using a free Kobo tool for 84 sites, which are self-assessing right now. And the same is for client feedback. They hope to continue using free tools like Google Forms that they find easy to use. Next slide, please. My very last slide. So I think our key takeaway, which is not just for applicable for digital interventions, but overall, we have to keep the private sector in the center of design thinking. But that's not enough. Like, especially when it comes to digital interventions, we need to continuously innovate and adapt. We need to see how the private sector responds, and we need to change. And a lot of our dashboard elements and our checklist priorities were revised along the lines of provider feedback. It's also very important to understand what the private sector values. Our takeaway so far has been that we need to link all interventions with business value, and we had to highlight the business value of collecting this data, using these digital interventions, and making database decisions. And that's how we got ownership of these interventions. However, my very last point is that we will have more insights on what private sector values, what they will continue on their own, and it will all be much clearer once results from the approach come in at the end of the project cycle, because that's when we will be moving to check-in and we will be seeing what they sustain on their own without much input in terms of coaching from us. And these insights, they will inform future project designs as well as priorities. Thank you so much, and sorry if I rushed through the presentation.
No worries. Thank you so much, Srishti. And I think that last slide was a very good note to sort of end our lineup of presentations on for today. Very key insights related to the private sector. Before we move on to our discussion, I believe next up we have our, an address or some remarks from our USAID colleagues in Nepal.
Hello. First of all, I want to thank each and every presenter. I think they did a wonderful job and they give us such insight to what this community practice would gain. And I think what I really appreciated was there was a very good link on each of the presentations. So we were able to have the flow of thought at what we want to come and look at it at the end of the day, or what we want to learn from this session. And I think we were very clearly saw the market intelligence provided by Shankar, which gave us a very good insight. And then we slowly moved on to see how the importance of local and sustainable solutions is required, because everybody did talk about, in some way or other, touched upon the donor decrease in fund, importance of capacitating the local partners, and the most important one, the most sustainable one, is the private sector that needs to be involved. Having said that, it's not easy to say that we need to engage private sector. We already looked at some of the policies that are there that we need to work on, and the capacity that I think the private sector also talked about in all of us being able to work on those front. So with that, I think what we really need to start working on is on how we really put all these things together, and maybe with our projects that are there, each of them contributing different segments that we are looking of ultimately engaging private sector, looking for local solutions, and also capacitating at the same time. And we also want to recognize the UNFPA, a global partner, to ensure that policies move forward. So I think we have to rely also on our global partner UNFPA to look at the policies of sustainability, and is also one of the UN's goals to look at the sustainability. So I once again want to thank everybody, and over to you, Farhan.
Thank you so much, Ivana. Yes, and now we have some time. We had hoped we would have more, but because of how meaty our presentations were, we have, I would say, around 7 to 8 minutes for a discussion. So please, I have noted two comments. One is from Jeff, which says, in a market this small with price restrictions, prospects for PPP are pretty poor. So if someone wants to speak about that, I feel like it's somehow related to Netra's point as well, that talks of how can the local market for commodities be strengthened for both the public and the private sector sustainably. So happy to have people chime in. Shankar, I saw your video come on. Do you want to respond to either one of these?
So I'm not going to attempt to answer Jeff's question, but here are some markers. I think the way, so Nepal continues to be a small market, but if you look across the spectrum of manufacturing to retailers, I think it's important to mention that we see the early emergence of how they are thriving post-COVID after having cleaned out all their balance sheet. Interestingly, Jiblal mentioned that they are between India and China. And so this reliance on these two big pharmaceutical hubs, in fact, Nepal borders three largest pharmaceutical hubs of both two countries, right? So despite that, I think one of the positive things we saw is that manufacturers have a very clear idea of how they can grow the OCT and the EC market. And condoms, and it's a good prediction that Jiblal and their team agree that if status quo continues for social marketing, they will be taken out of their oral contraceptive, condom, and EC market. So we're seeing that the market share is being eroded away for CRS by private marketers and local manufacturers. So that's one insight. Second is, even if when it's a small market with price restrictions, social marketing has left a wide opening on the pricing part. Interestingly, Nepal has higher pricing points for second generation oral contraceptive pills and condom 3 pieces than India. As a community of practice, I think our aim and intention is to transform and transport good practices. Unfortunately, Nepal from India and Bangladesh learned a couple of bad practices. In 2015, I think they incorporated not only the maximum retail price, which is a very strange concept for the globe, but not for India and Bangladesh, right? In 2015, Nepal adopted maximum retail price and incidentally price ceilings. That comes out as one big rules and regulations part. Going back to Netra's part on federalization, I think given the context of a small market, even local supplies at a federal level is going to be extremely uneconomical. There are only two revenue streams for Nepali traders and manufacturers: wallet share of users and public tendering. Public tendering has got a lot of hoops to jump through, and that's not an attractive proposition. So many of them, at least in family planning, have decided to place their bets on condoms and oral contraceptive pills. Having said that, I wanted to mention one clear thing. I think the small market, large market bit is a little nuanced. Nepal's market of 1.2 million DMPA intramuscular is 1/3 of India market. And we now know that that's very supply led. If supplies are made for 3 million in Nepal, then 3 million would sell. Similarly for implants, where UNFPA subsidizes it, 40,000, 50,000 comes into the country, it's offered. So if real markets were allowed to play, I would assume that Nepal for DMPA is as big as a market as India currently is. So those are some context on how DMPA, SC, and implants can be shaped. Thank you.
Thank you for that insight, Shankar. Anyone else with any questions, comments, thoughts, ideas? Feel free to come off mute and, give your thoughts. As I mentioned previously, a lot of the discussions here were very representative, I think, of things that, we have seen in other countries as well, which is why we are also thinking of, having a more thematic leaning in some of our discussions in the future, because, we saw questions around, as I mentioned earlier, youth and how do we get to youth, and, that question of youth prefer private sector, but they're not going to it. So what do we do about that? There's the digital aspects that Shrishti spoke of, and Suzanne spoke of as well. So there's this whole theme of, digitization and using digital tools to reach especially the young people who we assume are quite tech savvy right now. And then there are also elements around data sharing and, creating that market intelligence sort of environment that I believe Jiblal spoke about as well. So any other thoughts from people? Okay, looks like all the presentations were, quite clear for today. I don't see any outstanding questions in the chat or from people. Yeah, so, we will share, as we always do, a summary of these discussions and a link to the presentation. We know who our speakers are. If there are any questions sort of beyond today as well, please let's feel free to contact each other. The whole idea behind creating this as a community is to create those connections so that people can talk to each other. I think there being no further questions, Andrea, do you have anything to add? Ben?
Yeah, thanks. Thanks, Farhan. And echoing my appreciation for all the speakers and for comments, observations from Ivana, our colleague at the USAID mission in Nepal. I think the sort of a final observation I had is around, it sort of gets back to the point that Jeff Barnes raised, and certainly Shankar referenced that under FHM Engage, he completed what we would call kind of a rules and regulations analysis. And certainly engaging with the government of Nepal and sort of looking long term, and we realize it's a long game, for what are private sector market friendly environments, right? And that's where we really hope to advance the idea of stewardship is not just the government being a steward or the steward of markets, but also how can all the various actors from the private sector and funders and so on come together to align on what the challenges are and work on chipping away at those rules and regulations that can create a more sustainable environment, whether it's pricing for contraceptives, oh, and I have a dog barking, sorry, or relative to registration of products. So I think those are where, it's just about actually being able to take the time and do the work, frankly. So that would be my comment, and then over to Ben, because I see he has his hand up. Thanks.
Thank you, Andrea.
Thanks so much. Thanks, Andrea. Farhan, thanks a lot. And to all the presenters, thanks so much. I mean, it has been incredibly rich, the whole hour and a half. So, huge kudos for all of you and for all the work you're doing. One of the things that Navraj had mentioned in his presentation is UNFPA has got a new policy. And if I can summarize it, it allows us to try and think about moving towards total market approaches. So in a more deliberate way, the UNFPA focus, as you all know, has been to supply the public sector. And we, as we move to financial sustainability, as donor funding begins to come down, we're thinking much more deliberately about moving, really think about the private sector markets, how we can support the development of the private sector market. We're aware that USAID and other partners have got much more knowledge and experience in that domain. So we will be working with you on these issues. But I absolutely envisage that over the next 6 months, UNFPA will want to be back in touch with everybody who's presented today to think about how we can move forward with you. This is not something I envisage UNFPA would lead, because you've got more knowledge and experience in this area, but we see the critical importance of trying to ensure that UNFPA support really skews towards poorer communities, low wealth quintiles, and then towards the bottom of the market, those who are able to pay a little bit for their services should be encouraged to do so. But we also think this can create an opportunity at the higher up the market for consumers. And I was very struck by the comment about youth populations wanting to go to the private sector. That again, I think, is in the mix of the things that an initiative that we could develop together could try and address, try and understand that a little bit more. But thank you all very, very much. I'm inspired by this conversation, and I really hope there'll be more to come. Farhan, back to you.
Okay, thank you, Ben. Right on time. We are at our 1.5 hour mark. Thank you everyone for joining. Thank you to our presenters and all their great presentations. We will have our next session in July, tentatively at the end of July, and we are planning of having a focus on Zambia as a country. So, please do reach out if you have any thoughts, ideas, or any tools, approaches that you want to share with us. Thank you so much, everyone. Have a good rest of your day.
Thanks, everybody. Bye-bye.
Bye.
Thank you.
Bye.
Bye-bye.
Thank you.
Thank you. Bye-bye.